Dear friends and colleagues, welcome to this additional session following the TIO meeting where we want to discuss the poll results. My name is Nicolas Van Mieghem from the Erasmus University Medical Center, and I'm joined by Ajay Kirtane from Columbia University. So Ajay, welcome, and how are you doing?
Great, and I think really relish this opportunity to go over these results because we tried to do it a little bit during the meeting, but I think that we both felt that this would be a nice springboard to discuss some of the topics that came up in the meeting, almost recap the meeting in some sense, but then get a better sense of what people around the world are doing, because it truly was a worldwide audience that we saw for the meeting.
Yeah, so let's bring on the first poll results. And this was the first one. It related to TAVR in general. Should it be the default strategy for symptomatic patients over 75 years old? And I think the overwhelming result there was yes. I believe that this reflects the opinion in the majority of the cardiology community. How is this adopted now in the United States? Is it already happening that patients over 75 years old are selected for TAVR?
Yeah, I think, here in the US, we still have the heart team approach, and some of that's interestingly driven by regulatory issues and reimbursement. So you're sort of required to have a consultation. And I think that's appropriate because, the age cutoff is not something that is every 75-year-old is the same as every other 75-year-old. There are different levels of 75. And then some of it's also driven by the patient. Sometimes, patients will often opt for a less invasive procedure. But for some patients for whom, for instance, there's extensive coronary disease, it's unrevascularizable, those patients may want to have a TAVI or a TAVR, and in reality, they may be better served with surgery if they're in great physical condition to be able to go into it. So I think that in general, this prevailing sentiment makes sense, but they obviously have to be individualized. What's happening in Europe, Nicholas, in your practice, your center, and beyond?
Yeah, there's quite some variation in Europe. And for instance, in Germany and I think in Italy, they have become more flexible. In the Netherlands, it's becoming a different story in terms of reimbursement. The regulatory agencies, they are looking into reimbursement and to restrict it only for patients who are at high or inoperable risk, because they still believe that the data on lower risk patients is not as compelling, which is quite a surprise to me, because I think it is quite clear that even in the low risk trials, we were talking about patients with a mean age of 74 years old. So there is a little bit of a challenge there, but I hope that eventually rational thinking will prevail here.
And has that changed, or that's just how it's been? Because some people say, well, let's wait for longer term data, which is totally reasonable to do. But my sense is it's been like that, or is it ratcheted back up again?
It's more like it has come to a standstill, and also some kind of an unwillingness to accept more recent data. But then on the flip side, we also have to acknowledge that the low risk trials, they were only having 1 to 2 year follow-up. So I agree that durability is an important aspect in the discussion in lower risk patients.
Yeah. But for surgical valves too, because we don't have full durability data on the newest surgical valves that are being used either.
Exactly. I think the quality of the surgery literature is going up dramatically in the last couple of years.
That's right.
Okay. Another poll question. What was the Achilles heel for TAVR? There were two, PVLs and conduction disorders, and especially the need for pacemakers. I don't believe that this was a big surprise. This was as expected. Anything to comment there, Ajay? I don't believe so.
No, I don't think so. We did have some other discussions a little bit about the stroke issue, and it's interesting that was not picked at as either 1 or 2 here. But I think for a patient going into a procedure like this, that is something that's of concern, and there are different ways to deal with that that are controversial / being studied. We had a very nice discussion during the meeting.
Yeah, and on top of that, I think we have the protected TAVR trial currently ongoing, 3,000 patients that are being randomized between sentinel embolic protection versus control. That will definitely shed some more light on the discussion. All right. Then surgery, the reference to treat severe functional MR. 71% of patients agreed with that. How is your stand to that?
Well, I mean, let's face it, right now, there's not a lot of surgery being done for functional MR. So I'm wondering if this was somewhat of an issue with the complexity. It seems like a simple question, but the complexity of the mitral valve, because the reality is, you know, even this distinction between degenerative and functional is something that in practice, many people have, you know, general cardiologists, internists have a hard time differentiating. And then if it comes to functional MR, for true patients that have low EFs, most people are not actually going for surgery. So I think this is pretty interesting. I mean, Nicholas, what do you think about this? Is this some reluctance to accept the COAP data, or where is this at?
I was totally surprised, because the surgical literature on that topic does not look promising at all. I mean, I think that the data is relatively negative, and I think the only positive results that we have to treat functional MR is basically COAPT. So I was definitely surprised, and I think we will see cardiology community start to switch to catheter-based therapies, but definitely it takes time, and the poll definitely shows that too.
Yeah, I mean, I almost wonder if the question was, is medical therapy the standard to treat functional MR? Okay, that I understand, because yes, you have to optimize the patients medically first. But if you're going to do something, you know, most centers that have access to MitraClip, even the surgeons are saying, you know, go for clipping rather than operate on a truly functional MR.
Yeah, that is reality, and I think you touch upon an important basic principle, and that is medical therapy first. The patient needs to be on maximally tolerated medical heart failure therapy first. All right, that brings us to the next one. Patients with severe tricuspid regurgitation are underserved and should undergo valve treatment. That was an overwhelming, almost 90% yes. Wow, I was a little bit surprised about that, because, you know, we are used to the forgotten valve, the tricuspid valve as the forgotten valve. That is definitely not reflecting our practice. Although I do see a change, we do see more and more referrals for tricuspid regurgitation, but there's still a lot of work to be done, and also a lot of research to be done in that field.
Yeah, I completely, and I think that the natural history of this and understanding which patients are the ones that need treatment, this is far more nascent in a sense than the mitral regurgitation story, at least in my opinion. So we need more data for this, but for those that are super symptomatic, we know that oftentimes they don't even get referred for surgery as well. So this may be something to look at, but we need more data.
Yeah. Okay, switch to the coronaries now. Treatment of chronic total occlusions has a significant impact of clinical outcome. I'm kind of skeptical on that one. 86% said yes. I'm not so sure. I think patient selection here is the driver, or should be the driver. You have all these, the big centers, they have their CTO experts, and they take on quite a lot of cases. And I'm not sure whether the very complex procedures that they are doing, and often successfully doing, is making a big difference. Also there, in that regard, I do believe that we need more solid data to support sometimes quite aggressive PCI techniques. What do you think?
No, I agree. I think that the rate of adverse events is certainly higher with CTO PCI compared to non-CTO PCI. And there's a situation in interventional cardiology where it's a technically challenging area. And there's no question that these are skills that are not your conventional PCI skills. And so people sort of need to do more cases to get facile. But actually what ends up happening at sort of these mature referral centers is we turn down a lot of cases, but that's because we have enough volume for the clinically legitimate indicated cases, where those that don't need to be done because the patient doesn't have any symptoms or otherwise, we sort of leave them alone. So the challenge that we always get is for people who want to learn how to do it, they need to get a certain end, but we want to make sure you're doing it for the right reason. I think that this question, to me, the reason it was probably answered this way, my opinion, is that if you have a symptomatic patient with a CTO, these people, at least in clinical practice, if you pick the patient right, their symptoms dramatically can improve. And I personally, you can do a sham controlled trial, and there are trials going on like that. Shine CTO is one of them. But I'm not convinced of that. I don't need to be convinced of that. So that may be why this was answered. But in terms of other clinical benefits, it's a little bit more questionable. There are maybe some EF improvements in certain populations, although the randomized trial data doesn't support that. But really, we're talking about symptoms for the most part, and that's why people have to be selected.
Yeah. All right. CTO, PCI should be restricted to selected operators. I think we touched upon that. I think the community seems to agree on that. It is a more complex technique to be mastered, and you need volume to do that. So I think we touched upon that. Every cathlab should be able to perform atherectomy. Ajay, what do you think? Is that really true?
Well, look, I think that in the U.S., we have a third of hospitals that do PCI that don't perform atherectomy, but that might be because of access issues to primary PCI, because you rarely need to use it then. But I think personally, in this day and age, with the types of lesions that we're seeing in the lab, if you don't have strategies to deal with severe calcification, it's going to be a problem, and you're going to do a disservice to patients. So it's because people put in underexpanded stents, and there are other issues. Now, there may be other technologies out there like Shockwave that can sort of minimize this, but even Shockwave, as you know, you have to be able to deliver it. So at some point, you're going to need to know all these techniques. And my feeling is that the ability to treat patients in the current era, where we're seeing older patients, more calcified lesions, you got to know how to do these things. And if you don't, then enlist a colleague who can help you with that case so as to be able to treat the patient more effectively.
I agree with that. I agree that every cath lab should have that knowledge and that technique on board, but you need proper training, and potentially not every interventional cardiologist will do the cases, but at least every center needs to be able to do these cases. Yeah. Is atherectomy underused in 2020? Well, I would definitely agree with the 81% who believe so. And I think why? Because, high volume centers, they have embraced atherectomy and for instance, also lithoplasty. But also, I believe that invasive imaging plays an important role here in selection. When do you need atherectomy? When will atherectomy make a difference? And when will you prevent stent underexpansion, malapposition, and all those kind of stuff? So I think one will come with the other. I think the more invasive imaging you will apply, the more you get sensitive to the need for atherectomy.
Yeah, couldn't agree more.
All right. Unplanned revascularization is an important clinical endpoint in trials evaluating invasive versus medical therapy in stable coronary artery disease. Very curious about your opinion here, Ajay.
Well, look, I mean, it depends what you're weighing it against. If it's an upfront procedure versus a delayed procedure, then it's a procedure kind of either way. The question is if it's with an MI. So if it's an MI, spontaneous MI that's occurring late, that's driving the revascularization, okay, that is a problem. And so my feeling on this is the way I read this is that at least in the ischemia trial specifically, this trade-off of early MIs that are periprocedural with then increasing and then sort of overwhelming the early events, so to see further curve separation, is something that I think we need to watch. And I just hope and I pray that there's going to be longer-term follow-up from the trial that will allow us to get a better signal on that.
But in your opinion, if we then look at ischemia, where the primary endpoint was not including any revascularization, but 20% of the control arm ended up having a revascularization. So would you think that is a relevant endpoint, the revascularization per se, or do you agree with the ischemia investigators that it's quite fair to just stick to the hard clinical endpoints?
I think that for me, the crossover revascularization, if it occurs in a stable patient that has more symptoms, to me that shouldn't be included. But if it's a crossover revascularization because they're getting unstable or they have an MI or something like that, then for sure it should be included. But the thing is if it's an MI, then it is going to be included if it's a hard endpoint. So I think it's you have to, from a patient perspective, you have to look at, I see this person in front of me, what's going to happen to them over the next 5 years, and how can I avoid all the bad things, including a paraprocedural bad event.
Yeah. Well, I think there are several ways to look at that complex topic, but I think it's fair to say that ischemia is not the final trial on this topic. There will be more trials.
No, and there's not one answer either. That's the other thing. You can see two answers within the same trial. It's just people don't like seeing both. They kind of put themselves in one camp or another, but the reality is it's one trial.
Yeah. We had another poll question on TAVR versus SAVR, whether recovery time is important. I think that was an overwhelming 96% yes. I think that doesn't require any further comment. But then this one, every cathlab should be able to perform PCI or using also mechanical circulatory support if needed. 82% agreed with that statement. What is your take on this? That's especially in light of the recent publications in JAMA and Circulation on Impala.
Well, look, I mean, I think that if you're in the cath lab nowadays, and this is all encompassing. This question encompasses shock and non-shock patients, but there are going to be sick folks that come to your hospital and that you need to be able to treat. And I firmly believe that in the sickest of the sick patients, it's almost impossible to do a complete revascularization or even a partial revascularization without supporting the pump in some way. So I would actually agree with this statement. But what I also feel is that we really need to do a better job at figuring out who needs the support and who didn't need it at all. Because for those patients that didn't need it, putting in a 14 French sheath like we discussed at the meeting has complications associated with it.
Yeah.
So that's really where the data is needed. I think that it shouldn't be you throw it all out. The data should be, okay, we need these tools, but let's figure out what the best way to optimize the use of these tools is.
Yeah, and at the end of the day, there is a knowledge gap and also a skills gap. And I think we need to try to fill in that gap before we open up this kind of large or mechanical circulatory support for each center. But I agree with you that sometimes, these sick patients that we're taking on these days, you cannot treat them or offer them complete revascularization without safe support with mechanical circulatory support.
Yeah.
Okay, I think that was those were all the poll questions. I think they were quite interesting. The results were not always as expected, but understandable. And I think there are several ways of looking at what the needs are in our current practice. I think TIO addressed a lot of those things during the meeting, and it's always good to reflect on the polls with an expert like Ajay afterwards. Ajay, what do you think about the TIO meeting next year? Is this something that we need to proceed, or do you believe that we're going back to face-to-face meetings, or is this something that will stick around?
Well, I think first is it's tough to know what's going to happen with face-to-face meetings. We all miss seeing each other and hanging out with each other, giving you the bro hug when we see each other thing. But besides that, there was always a need for online education because not everybody can attend everything. And my feeling on this particular meeting was that it was great. It was live cases. They were very educational. There were great discussions, and there's going to be a role for it. And personally, unfortunately, with COVID, and we pray for everybody around the world that who are all fighting this together, that it's going to be around with us for a while. So we certainly are looking forward to doing this meeting next year. We want to keep up the interactivity component. We want to keep up the training components and the discussions. So certainly looking forward to it. I think for everybody, speaking on behalf of everybody who participated in it, we all were pretty energized with what happened. I think people now are a little bit zoomed out, if you will, but at the same time, if the educational content is provided in a way that is instructive, it can be really empowering because that is a great experience to see something done well. So for me, that was how I felt about it. I'm obviously biased because I'm participating in it. So I fully accept that, but I'm looking forward to what the future can offer.
Thank you very much, Ajay. It was, as always, a great pleasure to see and talk to you. I hope to see you in person soon. And for you, ladies and gentlemen, thank you very much for following us, and see you on the road. Bye.